Good morning. In the next few minutes, I will talk about the individualization of oxygen therapy and non-invasive respiratory support in COVID-19 patients. These are my conflicts of interest. With any form of respiratory support in hypoxemic patients, our goals are common, and these are to improve oxygenation, fostering lung recruitment, to support the respiratory muscle, and to buy time while preventing additional lung injury, because non-invasive respiratory support does essentially nothing for healing the lung. So we just want to buy time for the etiological treatment to be effective while preventing additional lung injury. And of course, we want also to optimize patients' comfort. One important thing concerns the risk of non-invasive respiratory support in spontaneous breathing hypoxemic patients. And the main risk is the so-called patient self-inflicted lung injury, which is caused from one side by the increased respiratory drive and respiratory effort, and the lung inhomogeneity from the other side. Altogether, this phenomena may increase the transpulmonary pressure, which is the main factor causing injury to the lung through volume barotrauma, atelic trauma, and thus worsening the lung function. The non-invasive respiratory support can be applied with different techniques. The high-flow nasal oxygen is the most recent. And then we have the classical form of non-invasive ventilation. And under this term, it is often included CPAP, continuous positive airway pressure, and pressure support ventilation. And both these techniques can be applied through a face mask or through an helmet. This slide summarizes the difference of this technique as compared to spontaneous breathing with standard oxygen. As you can see here, this is a tracing of airway pressures over time. And with spontaneous breathing, you can see small oscillation around 0 centimeter water of pressure. It is the atmospheric pressure, and this oscillation corresponds to the inspiration and the expiration. With the nasal flow, we have the same breathing pattern around an increased airway pressure, and particularly with nasal flow, we can increase the expiratory pressure. So we set the gas flow, for example, in this case, 60 liters per minute, and the patients breathe with this small oscillation around an increased airway pressure. And in general, the amount of pressure we can generate with this device is not very important. With 60 liters per minute is around 5 centimeter water. And the main difference between this technique and CPAP is that with high flow, we set flow, not pressure, but we can generate pressure. With CPAP, we set pressure, not flow. And in general, the level of pressure we set is higher than with high flow. So we set a level of pressure around which the patient breathes. With a classical non-invasive B-level pressure support ventilation, we set 2 levels of pressure. One is the expiratory pressure, and then we have the inspiratory pressure. So with this technique, we can add a form of inspiratory assistance. Concerning the non-invasive respiratory support in COVID-19 patients, we could refer to several guidelines released by scientific society around the world. And you can see here that across all these guidelines recommendation, all these techniques of respiratory support were recommended more or less. And this was due for the results obtained with this technique in hypoxemic patients without COVID-19. For reason of time, when talking about non-invasive ventilation, we refer to the B-level non-invasive ventilation with pressure support. But many things that are true with the B-level pressure support ventilation can be also applied with CPAP, even if this is exactly not the same thing. So concerning nasal flow, we have studies who have shown the benefit of this technique in hypoxemic patients, like this Floralis study, who compare nasal flow to oxygen and to non-invasive ventilation, showing that at least in the most severe patients with nasal flow, the intubation rate was lower as compared to the other technique, as survival was greater. Other studies have more or less shown the same thing. And this meta-analysis, considering 9 studies, more than 2,000 patients, although comparing nasal flow with a conventional oxygen technique, although not showing any difference in terms of mortality, did show, however, a reduction in the intubation rate with nasal flow as compared to standard oxygen, with very low heterogeneity across the study, so very consistent results. And in fact, the accompanying guidelines for the use of nasal flow in different contexts recommend using nasal flow instead of standard oxygen in hypoxemic patients. And this was a strong recommendation, although the level of evidence was, of certainty of evidence was moderate. What about non-invasive ventilation? Well, studies like this one have also suggested the benefit of using non-invasive ventilation in hypoxemic patients. For example, in this study done in ARDS patients, use of NAV as first-line intervention results in a success rate of approximately 50 to 60% of patients who avoided intubation, and in these patients, oxygenation increased, while this was not observed in failing patients. And in those patients in which non-invasive ventilation was applied successfully, we observed also a reduction in the mortality and in infectious complications. Taking altogether of the study about the use of non-invasive ventilation in hypoxemic patients, 9 randomized controlled trial, meta-analysis showed no difference in terms of mortality between simple oxygen, standard oxygen, and NAV. There was a significant reduction in intubation, but with a very high heterogeneity across the study. So the results were not really consistent, and these corresponded to the lack of recommendation about the use of NAV in these patients. I think that we should consider at least a couple of factors. First factor is severity of patients. We know that the success of this technique, both nasal flow and non-invasive ventilation, may depend upon the severity of patients. For example, in this study, which is the secondary analysis of lung safe study, patients with NAV had a similar outcome as compared to intubated patients. In patients where the PO2 FO2 ratio greater than 1:50, so less severe. In the most severe, the survival probability with NAV was lower as compared to patients who were directly intubated. And this difference was mainly due to the worse outcome of patients who underwent NIV, then failed, and were subsequently intubated. The same thing, essentially the same thing, is true also in patients with nasal flow. For example, in this retrospective study in COVID-19 patients, it was clear that patients, the most severe patients, had a very high failure rate, more than 60%, while in the less severe, the success rate was 100%. There was no failure. So this leads to a first conclusion that is that this technique of non-invasive respiratory support are safe when applied in the less severe hypoxemic patients, while we should be more cautious in the most severe patients. A second consideration concerns the interface for applying non-invasive ventilation specifically, because applying non-invasive ventilation with a face mask and a helmet may not be the same, as suggested, as shown by this study done in patients with ARDS and an average PO2 ratio 130. And in this study, patients treated with helmet had a significant reduction in intubation rate and a significantly higher survival rate as compared to patients who received face mask need. And one explanation could be that with the helmet, the applied PEEP was higher, while with face mask was not possible to apply a higher level PEEP because of patient's intolerance and excess air leak. So the helmet non-invasive ventilation may ease the application or more protective ventilatory settings. So it could be logical to consider we have the nasal flow, which is recommended. We have helmet that can be better than face mask and non-invasive ventilation. But we did not have any direct comparisons between nasal flow and helmet. So we did this comparison in a physiological study in a small subset of patients with acute hypoxemic respiratory failure. And what we found is that with helmet, we had a greater improvement in oxygenation as compared to nasal flow, with a greater decrease in the expiratory effort, in the respiratory rate, and in dyspnea. And this benefit of helmet as compared to nasal flow was seen especially in patients who were more severe, those with more severe hypoxemia and showing a more vigorous inspiratory effort while breathing with nasal flow. Therefore, we want to confirm these results and looking at the difference in clinical outcome when applying this technique. And we performed a subsequent randomized controlled trial in COVID-19 patients with severe hypoxemic respiratory failure and an average PO2 ratio of 100, and 109 patients were randomized to receive non-invasive ventilation with helmet or nasal flow. And the primary outcome was the number of days free of respiratory support within 28 days. And the primary outcome was not statistically different. This is the number of days free of respiratory support with helmet and with nasal flow. However, with the helmet, we observed a significant reduction in the intubation rate. So this can also say that nasal flow may be applied as a first-line treatment in all patients, and then probably in the most severe, we can shift rapidly to helmet non-invasive ventilation if nasal flow is not really giving very good results quite quickly. One problem is that with nasal flow, at least at the beginning of the pandemic, there were concerns for the risk of aerosol generation with this procedure. However, subsequent studies have shown that simple measures like the positioning of a simple surgical face mask over the nasal flow may significantly reduce the environmental contamination with this device and the aerosol generation, always, of course, in association with the use of PPE by the healthcare personnel. Altogether, these measures may allow to apply nasal flow quite safely. So the conclusion is that, as anticipated, nasal flow and IPEEP continuous IPEEP with helmet NAV could be probably the preferable technique for non-invasive respiratory support in hypoxemic respiratory patients, in patients with hypoxemic respiratory failure, including those with COVID-19. Probably helmet NAV may be preferable in the most severe. With any technique, it is important careful monitoring with the simple physiological measure like oxygenation, PCO2, respiratory rate, dyspnea, in order to avoid intubation and protective ventilation, because we know that delaying intubation can be associated with a worse outcome. Thank you very much.
Hello, everyone. My name is Luigi Camporota, and from Geyser St. Thomas's in London. And it's a pleasure to talk to you about how to personalize mechanical ventilation in the ARDS patient. These are my conflicts of interest, but I have no conflict of interest for this presentation. So first of all, I would like to start with this idea, the idea that mechanical ventilation is a complex intervention that requires essentially various components, and you'll recognize the components on the right-hand side. It's a combination of Peep, tidal volume, driving pressure, respiratory rate, and everything, all the components of mechanical ventilation will contribute to the ergotrauma, and that will be the dose of mechanical ventilation. So the question is, how can we personalize this total dose of mechanical ventilation, but also looking at the single individual components of it? And the idea comes from, in a way, this paper when in this paper in 2007, essentially all the patients were delivered 6 mils per kilo of ideal body weight, tidal volume, and a plateau pressure less than 28. And yet, some patients had achieved lung protection. You can see at the top where the lung volume is uniform and there is no evidence of a distension. And yet some patients, you can see the two pictures at the bottom, did not achieve lung protection despite achieving the nominal tidal volume associated with best protection. And you can see there are lots of purple images indicating over distension. So then it becomes clear that actually lung protective ventilation is not just given a certain amount of tidal volume or plateau pressure, but is the interaction between the tidal volume, the lung characteristics, the mechanical characteristics of the lung recruitability, the level of PEEP, etc. So you can see, for example, that if the lung is small at the bottom, there's a lot of consolidation, the one in green, then the mechanics will be different from the one at the top. There might be more or less recruitability, more or less PEEP, and therefore the tidal volume that we add on top of this patient might determine the level of lung protection. So, for example, if we think about this example here, when we are asked to scale the tidal volume to the predicted body weight, it's very clear that the scaling is based on the relationship between ideal body weight and lung volume in health, but not in disease, because each patient with the same predicted body weight with increasing level of disease, and therefore the lung becomes smaller and smaller as the consolidation increases, then the same amount of tidal volume will cause an increasing level of strain within the lung, and therefore the ergotrauma of that patient. And this becomes very clear when you can see epidemiological data that says essentially it doesn't really matter what tidal volume you give above or below a 7 mils per kilo predicted body weight. The mortality does not change and the plateau pressure has less of an influence. But what is influential is the driving pressure. So patients who received a driving pressure which was above the median had a cumulative survival that was inferior, so there was higher mortality compared to the patients who had low driving pressure. And in a way, driving pressure is essentially the scaling of the tidal volume to the lung volume, or in other words, the relationship or the ratio between tidal volume and lung compliance. And so a high driving pressure, what it does indicates that that tidal volume is too big for the level of gas volume of that particular patient. So this is one of the ways that we can scale the tidal volume to the individual patients with an individual severity of lung disease. This is clear also from this particular study, which was the Lung Safe Investigators, where they divided patients in 3 groups: high compliance on the right, intermediate compliance in the middle, and low compliance on the left. And you can see patients with high compliance were essentially ventilated with, on average, with much higher tidal volume that we associate with protected lung ventilation, 8.5 mils per kilo predicted body weight. But if you can see the driving pressure is very low, 7.6 centimeters of water. Whereas if you compare it with the patients with a low compliance, those patients on average were ventilated with lower tidal volumes, but the driving pressure was excessive, 17 centimeters of water. So this is the importance and the difference between looking at just tidal volume per se versus scaling the tidal volume to the lung compliance, which is essentially looking at driving pressure. And once more recently, this paper has shown how the important is considering the level of compliance or elastance when we decide about tidal volume. So in patients with low elastance, so in other words, high compliance, there is very little difference in driving pressure in patients receiving low tidal volume or high tidal volume. But this difference becomes much more marked at high level of elastance. In other words, when the lung volume is very small. And importantly, we'll see the other point here is that at some point when we think about mean of ventilation and therefore CO2 clearance, we need to decide whether or not we are going to increase or decrease the tidal volume and therefore the driving pressure, or whether we are going to alter the respiratory rate. And this paper, in a way, gives us a little bit more information what to do. And for example, if you take into consideration this formula, you multiply the driving pressure times 4 plus the respiratory rate, what you can see here is that we can have a average number, so 4 times the driving pressure plus the respiratory rate. But you can see which factor is better in terms of personalizing in patients with low compliance. You can see the pink curve versus patients with a higher compliance, the blue curve. So if you follow the one with a low compliance and you think about increasing the driving pressure from 21 to 27 by increasing the tidal volume, and as a consequence, the respiratory rate reduced from 45 to 30, you can see what happens in those patients. That number, it goes up from 129 to 138. And with that number goes up also the odds ratio of death. So these are the patients with low compliance. Whereas in patients with high compliance, the increase in tidal volume and the increase in driving pressure actually will decrease that particular number from 76 to 73. And as a consequence of that, the odds ratio of death would also decrease. So the point of that is the choice of tidal volume depends on the underlying lung mechanics and gas volume. Now, when we go to Peep, Peep is a bit more complicated. There's concept of best Peep, where we look at the combination of best lung mechanics, best gas exchange, but also best hemodynamics, because obviously Peep will have an effect on the venous return and therefore the cardiac output. Now, when we think about giving high PEEP, for example, and recruitment maneuver according to the open lung strategy, you can see that overall, and this is the Ards trial, there was an increase, a 20% increase in mortality at 28 days in patients who received a routine use of lung recruitment maneuver and high PEEP. So you can see the mortality, which was 55%. There were fewer ventilator-free days, and also there was a higher mortality in patients less than 7 days. So this is quite important first message. Now, the other message came from the Farlap trial, which essentially showed this was a study where they randomized high PEEP plus recruitment maneuver, and this study did not show any difference in terms of ventilator-free days, in terms of barotrauma, although there was a higher incidence of cardiac arrhythmias. So I think it's very important to say that when we use high PEEP and recruitment maneuver in all patients without any distinction about their recruitability, the overall message is probably deleterious. However, when we look at meta-analysis, you can see that there is no much difference between the higher PEEP and alone, the higher PEEP and recruitment maneuvers, or recruitment maneuvers alone. So no difference there. And also there is no difference whether we titrate the PEEP based on oxygenation or based on respiratory mechanics. However, we can say that some of the dynamic maneuvers that we can see following change in PEEP are very important. So first of all, it should be in patients who have a more severe ARDS, so 150 millimeter of mercury or less. You can see on the left-hand side, these patients have got higher chances of responding to PEEP. And also, you can see on the right-hand side, if the PEEP increase is associated with an improvement in PF ratio, then these patients normally will have a reduction in the adjusted probability of death. Also, it's important to understand which patients might respond to high PEEP or which ones they're going to be harmed. So this is a reanalysis of the Ards trial that essentially will show that patients who had pneumonia and were on vasopressors, they were more likely to be harmed by high PEEP and recruitment maneuver. And also, if you look on the right-hand side, a lower mortality following the increase in PEEP was only seen in patients with the highest quintile of driving pressure. The other thing is about phenotype, and we can see in this study that actually the lower PEEP was better in terms of mortality in the phenotype 1, which was the phenotype with the lowest inflammation, whereas the higher inflammatory phenotype with hypotension was better with a higher PEEP in terms of mortality. So taking into consideration the diagnosis, the lung mechanics, the inflammatory phenotype will make us understand a little bit more what to do with PEEP. The other point is that the recruitability is much more marked in patients who have lower lung compliance to start with. And so we can do a recruitment to inflation ratio to understand which patients might benefit from further PEEP increase and recruitment maneuvers. And you can see there that when we do that kind of test, about 2/3 of the patients are highly recruitable, whereas 1/3 are poorly recruitable. And the ones that are poorly recruitable, they tend to be stayed longer in the intensive care, so longer delays from symptoms to ICU and longer delays from ICU to intubation. So that's quite important to understand. Because if we don't do these tests and we apply high recruitability, high recruitment maneuvers and high PEEP, then the volume trauma that is generated by inflating the lung with PEEP will increase the inflammation and therefore the volume trauma, the static volume trauma. And one last thing which is important is that some of these patients will also we need to be careful when we transition the patients from a mandatory ventilation to a spontaneous ventilation. And you can see here, for example, if the respiratory drive is very high, as we can see from a PO1 that is greater than 4, or an occlusion pressure that is more negative than -15, these are the patients at very high risk of relapse and respiratory failure. And you can see about 2/3 of these patients with high drive and high effort had a relapse in respiratory failure compared to 0% in patients with low respiratory drive and effort. And in summary, I would say that mechanical ventilation, or the dose of mechanical ventilation, is dependent on a lot of the various components of mechanical ventilation. And we need to think about the individual components and how they interact with the diagnosis, with the phenotype, and with the lung mechanic of the patient. And with that, I would like to thank you for your attention.
Hi, my name is Jean-Luc Diehl. It's a pleasure to talk about how to interpret and deal with physiological dead space ventilation, thanks to G. Here are my conflicts of interest, and let's start by some general considerations. As you know, tidal volume can be divided into dead space volume, where there are no gas transfer, and alveolar volume, giving alveolar ventilations, where there are gas transfer. Considering that the partial pressure of a gas is proportional to its concentration, and using the classical Bohr equation modified by Henghoff, we can then obtain the physiological dead space value, VDVT, as a percentage, based on the record of expired CO2 and based on the assumption that alveolar CO2 for alveoli participating to gas transfer can be estimated by the arterial PCO2 from ABG. And moreover, using volumetric capnography, CO2 in function not of the time, but in function of the expired volume, we can split VDVT, the physiological dead space, into its two main components: alveolar dead space, using mathematical calculations, and conducting airways and instrumental dead space, using the same mathematical consideration. At this time, we can obtain volumetric capnography signals from the GE ventilator, but there is no implementation of the calculations of alveolar dead space, but we can obtain reliably physiological dead space measurement using high BG values. And this is very interesting as in different examples. The first example is ARDS patients, and this is a recent publication from my groups on respiratory mechanics and gas exchange in the early course of COVID-19 ARDS patients. It was an hypothesis-generating study. And we performed measurement in the 22 ARDS patients under a rather high level of PEEP, and we observed very high values of VDVT, physiological dead space, coherent with elevated PCO2 value despite a high respiratory rate for these patients. Also, we observed compliance value in the middle range for this patient. We also calculated ventilatory ratio, which is more frequently present in the COVID-19 literature. And we observed a correlation between ventilatory ratio and physiological dead space, as for non-COVID-19 ARDS patients. But the correlations coefficient was weaker than for non-COVID-19 patients. And we also observed no correlations between ventilatory ratio and total CO2 total body production, as it was also shown for non-COVID-19 ARDS patients. Comparing the values for VDVT and also ventilatory ratio, we found consistently higher values for these patients than in the existing non-COVID-19 ARDS populations, and typically in the seminal study from Nocton, published in the New England Journal of Medicine, identifying VDVT as a strong prognosis parameter for ARDS patients. And this is the hypothesis part of the study. Perhaps this could be in relation with pulmonary microvascular endothelial lesions and microvascular thrombosis, since endothelial lesions are key factors for coagulation activations. This could be explained by the expressions of ACO2 receptor on endothelial cells, perhaps more importantly by an endothelial dysfunction triggered by inflammatory cytokines, either hypoxia, complement activations, and this was in part confirmed by postmortem studies displaying very frequently, as compared to other non-COVID-19 ARDS, severe endothelial cell injury, apoptosis, death, swelling, and viral inclusion bodies in the endothelial cells, and finally microvascular thrombosis. We will perform further measurements. The VASCOV study, we are near starting the inclusions. The study will focus on clinical and physiological characterizations using this time alveolar dead space measurements. And we will compare these values with a biological parameter focusing on coagulations, fibrinolysis, and endothelial activations and senescence. This will be a prospective study both in COVID-19 and non-COVID-19 ARDS patients in 2 centers in France. Another interesting topic is acute exacerbations of COPD. And this is an example. We studied the physiological effects of adding ECOR using a low to middle CO2 removal device, adding it to invasive mechanical ventilations for severe COPD exacerbations. The design of the study was to obtain both an improvement in respiratory acidosis, and we aim to obtain also an improvement in mechanics of the patient. The first step was to calculate a target for PCO2, aiming to obtain normalizations of a pH value. For this goal, we used a measurement of a physiological dead space from the GE ventilator, and then we initiated ECOR, waiting for a decrease in stabilizations in native lungs VCO2, and then using the new value for VCO2 and the calculations of physiological dead space, we adjust respiratory rate for reaching the PCO2 target corresponding to normalizations of the pH value. The final measurements were obtained after stabilizations. Unfortunately, the CO2 removal device was not sufficiently efficient, and for some patients, the algorithm indicate not to modify the respiratory rate, and for some patients, the algorithms indicate to raise respiratory rate. So we were quite disappointed. But the good news, that for the normalizations of the pH and the adjustment of PCO2, or algorithms based on direct measurement of physiological dead space, worked very well. It was not exactly 7.4, since some patients exhibited mixed acidosis, including a metabolic part, and for these patients, we didn't decrease PCO2 below the normal value of 40 millimeters of mercury. And as I said, unfortunately, there was no modifications in the whole group for mechanical parameters, and notably for parameters of dynamic hyperinflation. We also studied 7 patients during the weaning phase of the invasive mechanical ventilations. And in these situations, the CO2 removal device, as compared to a period without CO2 removal, was associated with a frank decrease in work of breathing, as measured by esophageal manometry using the Campbell's method. But we also obtained VCO2 measurements from the mechanical ventilator, and we confirmed a frank diminution in the VCO2 displayed by the mechanical ventilator. Another interest could be to think about alternative strategy. This is another very severe COPD patients, and we use a different approach for the patients. As a first step, we aim to normalize, to keep the same value for PCO2 using a sweep gas flow of 1 liter per minute. And we lowered alveolar ventilations by decreasing respiratory rate and tidal volume in parallel to the decrease observed in VCO2 from the native lungs. There was a parallel in the 2 decrease, giving a stability for PSCO2. In the second step, we increased the sweep gas flow up to 9 liters per minute. And it works again very well using VDVT measurement for the first step. We kept nearly the same value for PCO2 and pH value. And we obtained, by decreasing respiratory rate and tidal volume, an improvement in parameters of dynamic hyperinflation. And as a further step, we obtained a partial improvement in respiratory acidosis. So by the monitoring of VDVT and by the general CO2 monitoring, we have the possibility to obtain a good equilibrium between parameters of dynamic hyperinflation and parameter of respiratory acidosis. Another interest is to add to a better understanding in some difficult situations or conditions. This was a very severe COPD patient under invasive mechanical ventilations and under CO2 removal by a highly efficient CO2 removal device. And we observed a decrease in the PF ratio from the period immediately before CO2 removal to 7 days after CO2 removal. And there was no clear clinical explanations, no pneumonia, no pulmonary embolism, no frank fluid overloading. And we obtained the solutions by looking after the ventilatory ratio displayed by the ventilator. It was very low, 0.3. Very different for the normal value near to 0.8. And this was explained by the fact that CO2 removal devices are efficient for CO2 removal but exert little to no significant oxygenation effect. So CO2 removal induced frank modifications in VO2 VCO2 ratio and the VCO2 VO2 ratio, the ventilatory ratio, as a part of the alveolar gas equations can explain a decrease in the alveolar PaO2, and the decrease in alveolar PO2 was the explanation for the decrease in PaO2 in the PF ratio. It was simply an indirect effect of the imbalance between VCO2 and VO2 as induced by the CO2 removal device, and this was not an indication for another medical complication. As a conclusion, we can clearly say that there are major interest and perspective for CO2 monitoring and especially for alveolar dead space measurement, with the possibility perhaps in the future to split physiological dead space measurements between alveolar dead space measurements in different conditions. We have the theoretical background, as in this paper from Lucangelo and Luis Blanc. It can give some perspective for better personalizations of our therapies, of a better monitoring of the patients, and a better understanding of the disease. Thank you for attention.